know, Chiara, very important in our daily life.
Yeah, absolutely.
We will tell you about, Tony.
I'll be interested to hear.
Well, dear colleagues, welcome to our monthly dialogue. As you know, dialogues are free and live streamed. Before we start, let me share with you a pleasant news. The impact factor of the European Heart Journal is now 35, increased from 29 in 2021 to 35 this year. But I strongly believe that this is an important metric, but a journal can do much more. A journal is also a link between authors, reviewers, and editors. And our dialogues are a good example of this link. Today is another important dialogue. It's my privilege to introduce Chiara Bucciarelli-Ducci, who is our deputy editor for imaging. And she's going to start the dialogue with Professor DeMaria. The title of this dialogue is Echocardiography from Inception to Future. But my mentor, Attilio Masseri, was used to tell me, well, Tony is one of the fathers of echocardiography. Please note that this is not a biased dialogue, because you can read Bucciarelli-Ducci, an Italian name, Crea, an Italian name, DeMaria is another Italian name, but I'm the only one based in Italy, in Rome, while Chiara is based in London, and Tony DeMaria is based in California. Well, his Italian is improving with the passage of time, but I must admit it's still imperfect. Now, Chiara, please introduce our important guest.
Thank you so much, Filippo, and what a honor to be here and be part of this dialogue with Professor DeMaria. I'll start introducing him. Professor DeMaria did his internal medicine and in Massachusetts and senior medical residency in New York. He started his fellowship in cardiovascular medicine at the University of California, St. Davis. Following completion of his fellowship in 1973, he remained on faculty until June 81. Then he moved to Lexington, Kentucky, to be professor of medicine and chief of the cardiovascular division of the University of Kentucky College of Medicine. Then in May 1992, he returned to California, this time to San Diego, as a professor of medicine and chief of cardiovascular division of the University of California at San Diego. In October 21, he made the Judith and Jack White Chair in Cardiology. He's been for over three decades, an international authority in cardiology and in the area of echocardiography. His investigations have led to the publication of over 450 articles, almost in all peer-reviewed medical journals. He's also the author and editor of 3 books, and I'm sure more than that. For his investigative work and teaching abilities, he has received many honors, including several internal medicine distinguished faculty teaching awards, Teaching Scholar of the American Heart Association, Distinguished Alumnus Award of the University of Medicine and Dentistry of New Jersey, and also honorary degree of the Kagawa Medical University and also University of Bordeaux in France. He was president of the American College of Cardiology in 1988 and president of the American Society of Echocardiography from 1985 to 1987. And finally, he has become editor-in-chief of the Journal of American College of Cardiology in January 2002 for over a decade. So it's really a huge honor for me as an imager to be here with Professor DeMaria and to have a dialogue about his career, and so that it can inspire all our audience, including the younger imagers and indeed younger cardiology trainees. Dear Tony, what can you tell us about your Italian origins? I think your name does suggest that you come from Italy. Is Italy always in your heart?
Well, actually, My mother was Polish, believe it or not. So I'm a mixed marriage, a product of a mixed marriage. But my father used to tell me that after they were married, they went to live in my father's hometown, which was all Italian. And in fact, all around us in our neighborhood were DeMarias. And my parents used to say, that's really not the correct pronunciation. Should be DeMaria. But when they came to the States, people said, oh yeah, DeMaria. And they said, whatever. And that's the way we pronounced it ever since. But yeah, my father had a small fruit and vegetable market. He started out going up and down the streets with fruits and vegetables. Then he opened the store. So as I grew up, I worked in the store. And as I said, we were in a heavily Italian neighborhood. So unfortunately, since my mother was Polish, the only language they shared in common was English. And I never learned much except the curse words in Italian.
That's funny. And where were your father was from? What region in Italy did you say?
Naples, the Naples region in general. He didn't live in the city, he lived in the outskirts, or his family lived in the outskirts. Yeah.
Excellent. So your enormous scientific achievement are clearly related to cardiology, but most particularly echocardiography. And was echocardiography your passion since the beginning of your career, or it was something you discovered during the way?
No, as a very junior fellow, my boss, Dr. Dean Mason, some of you may know that name. He was very prominent in his time. He asked me to carry on a project with a device that tracked the heart border on fluoroscopy. And so I worked with that a little bit. You do what the boss says, right? And so I worked with that, and I said, this is never going to amount to anything. But along the way, I read an article by this guy Feigenbaum in Indianapolis, where he was looking not at the epicardium, but the endocardium. And so I said, that sounds like a better way to do things. Went to my boss and I said, I want to go to Indianapolis to learn how to do this. And he said, don't waste your time. I can tell if somebody has mitral stenosis without that. But he let me go anyway. And I was what Dr. Feigenbaum in those days called a 1 week wonder. He had a series of people who came for 1 week. And so the world's literature in echocardiography could be fit in one loose leaf binder. The world's literature in English, there was more in German, but I didn't. So by the time I came back from Indianapolis, I had read the world's literature in echo twice. And it was off and running, and it was such a fortunate, lucky turn of events, because as the field exploded, as ultrasound became so important, I was blessed to be carried along with it.
A fascinating history, really. Almost that tells how sometimes career decisions are taken by chance, right? You just notice something is happening, you get curious, and you go against the recommendation of your boss, and then actually it was, a career change move for you. Fascinating.
Yeah, it was. The boss used to make rounds once a week, and he was making rounds this week with all the fellows, of course, and there was a patient with the recurrent chest pain admitted to the hospital over and over again with chest pain, and a very ugly EKG with deep T-wave changes, but never infarcting, but with mitral regurgitation, or so we thought. And so he expounded on this, and I said, you know, I've got this echo machine. I think I'll do an echo on this interesting patient, and turned out to have hypertrophic cardiomyopathy. And after that, he would not see any patient unless they had an echocardiogram first.
Yeah, amazing. But that explains what Filippo said at the beginning, that you're really, one of the pioneers of echocardiography. And it's nice to see your relationship with Feckenbaum from the early days of echocardiography, and how that first meeting with him then spearheaded your career in that direction. It's really, really inspiring and certainly fascinating. So you're clearly a pioneer in echocardiography and main players, since several years. Who has spearhead the interest of echocardiography since its inception, as we heard. What do you feel has been the most important scientific achievement, your most important scientific achievement?
So, when I started out, I saw myself as an echocardiographer. That's what I was. And very quickly, my perspective changed to using it as a technique to study mechanisms and prevalence and disease, not for the image itself, but what the image told us about the disease. And I hope I influenced the discipline a little bit that way. I suppose when people say, well, what was your major novel contribution, it would probably be in contrast echo, which we started very, very early. And I tell the story. We were, myself and Dr. Bill Balmer, who was my fellow and had joined us at the time, we were doing a dog experiment with contrast to try to use it to measure cardiac output. And, we said, I wonder what would happen if we injected some of this in the coronary artery. And at the end of the experiment, we said, what the heck, let's give it a try. So we put a catheter in the coronary artery of this animal and injected some contrast. And lo and behold, the myocardium lit up like a Christmas tree. It was amazing. Unfortunately, after about 10 seconds, the animal fibrillated and died. So we looked at it and we said, well, this could be an amazing technique, but of course, if we kill all the patients, we do it, and that's not going to be very useful. But that started. Now, we still have not breached that last hill of making it clinically useful every day in every laboratory. We've come up against the limitations of ultrasound and the agents at the moment, but I think contrast continues to play a more and more important role in ultrasound imaging, as it has in virtually every other form of imaging. No one does nuclear studies or cardiac CT and usually not MRI without contrast agents.
Yeah, absolutely. And so it's fascinating to hear. I didn't know this story about the echo contrast and the myocardium lighting up. So must have been really, really fascinating.
Well, it was an amazing thing to see. Yeah.
Have you had throughout your career? Have you had more opportunities to work and collaborate with Dr. Feckenbaum?
So we have remained very close friends throughout my career. I mean, he influenced me enormously. It's one of the things we value most in medicine. I think the ability to influence younger people, and he certainly did that for me. I mean, I was kind of going into the practice of medicine. I was married at that stage of the game. I had 2 children, and we were going to return to our hometown in New Jersey, and I was just going to practice cardiology. That was my goal. I told Dr. Mason when I took the fellowship, listen, I'll be here for a couple of years, and then I'm going into practice. And of course, I never did that, not for 1 minute, because I met Harvey Feigenbaum and Dean Mason, and they really were role models to move forward and do studies that would contribute to the knowledge base. They used to tell me, would you rather sit in the audience or would you rather be at the podium? Do you want to be told what is the best thing to do, or do you want to identify and tell other people what is the best thing? And when it's couched in those terms, it's fairly compelling to stay in the academic venue. So Harvey and I have, it's interesting you say that, because I just served as the Douglas Zipes visiting professor at the University of Indiana. And of course, as part of that, every hour or so, I met with a different faculty member. And when I met with Harvey, whose house I'd stayed at several times, we reminisced a little bit. He's 87 years old now, and he's still enormously active, doing research. So, I mean, there's hope for all. I know in Europe, oftentimes when you reach a certain age, you have to terminate some of your activities, but Harvey is still going strong at 87. I should only be able to do that.
Well, and all of us. So it's a huge source of inspiration, and surely for all of us in this audience. But I was particularly impressed by your words around the importance of mentorship, and looking at physician leaders in your field and just being inspired by what they've achieved, and what all of us could achieve in our career just by believing on it and believing the dream, let's say, and making it happen. And so mentorship and looking at leaders in the field is certainly something that we encourage the younger colleagues in the audience here to exercise, because it is important, and look for a good mentor in your career. So as you might know, I'm a cardiologist, I'm an imager, but I'm quite focused on cardiac MRI, and have been in the last almost 10-15 years. So I would like to ask you a question more broadly about imaging and where you see imaging going in cardiology, and in particular regarding cardiac MRI, that in the last few years has developed as a research tool into a clinical diagnostic tool, so much so that is indicated in most of the guidelines. In your clinical practice, I mean, obviously echoes remains at the cornerstone of the cardiovascular assessment, but where do you see a role of CMR in your particular practice, and particularly in the US? In which condition do you think it's particularly useful?
Yeah, so I congratulate you for being involved in cardiac MRI. As I said, I got involved in echocardiography early, as you are in MRI, relatively speaking. And so everything was a discovery. I mean, I saw some patients with left bundle branch block, so I reported what were the findings in these patients. I remember when we got two-dimensional echocardiography, I put the transducer on a patient with a myocardial infarction. For the first time, I saw a thrombus. and this huge thrombus going back and forth. So everything, if you get started in a discipline early, then life is very easy. You don't have to be very smart, as in my case. Everything you do is the first time. My view of cardiac MRI is that it's a very elegant and more precise echocardiography. Precise, at least from the standpoint of reproducibility. And so I look upon cardiac ultrasound almost like a stethoscope, right? It's almost an automatic part of the evaluation of most patients with known or suspected cardiovascular disease. It's quick. Now with the handheld echoes, you can carry them in your pocket. It's free of ionizing radiation, et cetera. It will never go away. But MRI can do all of those things better. And the question is how to use it. At least at the moment, and the hope is that there will be increasing information on tissue characterization that comes from magnetic resonance, that someday the holy grail is we may be able to see the coronaries without some blurring with MRI, and then it would be a spectacular technique, but the technology is much more complex. The instrumentation is more expensive. The examination is not so easily performed in so many areas, and so I think that MRI, at least in the foreseeable future, is going to be something that is done for a specific indication. In our case, cardiomyopathies forever, always getting MRIs. Viability continues to be a very important indication. To do an MRI stress test is a little bit cumbersome, and so there's still not much of that I'm aware of that's going on in the States, but the images can be spectacular, better than any other. So I think increasingly over time, we will turn to MRI, but I think it will always be after some immediate imaging like ultrasound.
Yeah, I mean, surely no doubt echo, remains at the cornerstone for sure. No, but the availability and the ease of use and the training aspect, I think, is very important. It's interesting you said the stress MR in the US. I think you're absolutely right, and I agree with you. In the US, it's not done extensively. But it's interesting in Europe, where I work, actually is done a lot more extensively than in the US, and so we're trying to really having the US colleague potentially embracing more this technique. In Europe, has developed a lot at the cost of SPECT, in fact. Particularly in the UK, there is very large numbers that are rising up. But work in progress, as you said, is a technology that still has to be embedded more into clinical cardiology. I'd love to ask you.
Yeah, I would just, not to interrupt you, but I think reimbursement has something to do with it. Whenever anybody says it's not the money, it's the principle of the thing. It's the money, and the way we get paid in the United States is by virtue of the services that we render, and so people who are taking care of the patients, the cardiologists, are going to be prone to do those studies that they're capable of. So reimbursement plays a little role, I think, in the United States, because not many cardiologists are doing stress MRI. They're doing SPECT, they're doing stress echo, and so it goes off to the radiologist. So rather than do that, I think many cardiologists keep the patients in their own practice.
Yeah, absolutely. My other role, I'm actually the Chief Executive Officer of the Society for Cardiovascular MRI, which is internationally based in the US, so I'm acutely aware of all the reimbursement issues. And so you're absolutely right, and I agree. So I would love to ask you more questions, which I will do during this interview, but I'll now pass to Filippo so that he has also the opportunity to ask you some questions.
Thank you, Chiara. Well, Tony, we have a large audience from the 5 continents, as usual. It's a very intercontinental dialogue, usually. And I ask our colleagues, please ask questions. You can do it via chat, or if you show your video, you can be directly involved with question. And Tony, please note that in order to celebrate your Italian origins, and you told us before your father was from Naples, just for this dialogue with Chiara, we came here close to Naples in Pompeii with a nice view on the Roman ruins to celebrate your Italian origins. But now let's come back to echo. What about the future of echocardiography? We had recent major developments like 3D echo, Doppler. What do you see in your crystal ball about the future? What will be the next important development of echocardiography in your opinion?
So I think there are a couple of areas that are developing. One is this whole business of artificial intelligence. I told you, well, one of the limitations, I think, of echo has been the reproducibility, the precision with which we make measurements, and I think that may well be solved by virtue of artificial intelligence, machine learning algorithms that can take some of the variability out. We see the images with an endocardial border identified. I can't see the endocardial border. I can see the line that's been drawn, but it turns out to be pretty accurate. So I think that will be a step forward. I think that we will get more information about intracavitary flow. We haven't looked at left ventricular filling dynamics in detail, the vortices that occur, the energy dissipation as the left ventricle fills. We've, in our laboratory, started to study that in hypertensives. I think that there's a great deal of information there, and in fact, from a clinical perspective, if you study what we've termed residence time, which is just the time any red blood cell spends in the left ventricle, then it seems to be quite predictive of the propensity to form clots and identify those patients who really should be anticoagulated. So I do think that's important. I think the contrast business will be solved, that we will be able to identify myocardial perfusion and perhaps even quantify it. And there's still lots of work going on. And interestingly, Filippo, when you put the contrast agent in and you subject it to a high energy ultrasonic pulse, you can get therapeutic effects. And I think that there's a potential future in using ultrasound for thrombolysis. It's even been attempted to be used to remove plaques. So I think those are some of the more novel directions that ultrasound is going in.
Thank you, Tony, for this wide perspective. And now I'm reading some questions, and we have a question from Nico Bruining. He's editor-in-chief of Digital Health. This is one of the journal of the ESC journal family. And the question from Nico is an important question. What about artificial intelligence applied to echocardiography? Do you think there's a potential there to improve the way we perform echocardiography by applying artificial intelligence?
So as I just said, I absolutely do, Nico. I believe that one of the areas I've personally been involved with, well, I've been in a couple. One area is just facilitating the examination. If you can use artificial intelligence to guide the performance of an examination, then you can enable the exam to be done by a much broader range of people, nurses, medical technicians, and there are several ultrasound GPS systems that are being developed using artificial intelligence that will guide someone in how to position the transducer. I've been involved in a project for interpreting stress echoes. And I think wall motion is the toughest aspect of interpreting an echocardiogram. And when you combine wall motion with stress, it becomes even more challenging. And there's good information, actually, Chiara, coming from England that using artificial intelligence, you can develop descriptors of ischemia that are more accurate than our conventional ways of interpreting the studies. And what I find most frustrating, it drives me nuts, if some algorithm can identify something that I can't see, what is it that they're identifying? And you know, that's the big bugaboo with AR or AI, whatever you choose to call it. The bugaboo is that something is being identified that enables that algorithm to reach a conclusion that we cannot reach, but we can't tell what it is that has enabled them to do that. But a long-winded answer, I really think that artificial intelligence is going to provide the precision for ultrasound that we haven't had in the past.
Thank you, Tony, for this wide perspective you open. But Nico is with us. Nico, you are muted. Other questions to ask Professor DeMaria?
I fully agree with Professor DeMaria with your long answer and the prospects of AI. But if I may add one more small question, what would be the top priority clinical problem what we should address first with the help of that new technology in your mind?
So, as you know, it's being applied increasingly now clinically just for quantitation. So that the measurement of simple things like ejection fraction, volumes, I think can be done more accurately and more reproducibly. So that's being done here and now. As I say, I think stress echo, there's many people who do it, but oftentimes it's not done as well as it might be. And I think that's an enormous opportunity. Now, there's many people who think that we can really make a huge difference in enabling others than highly trained technologists and physicians performing the echo exam. And then it would be more widely available and less expensive and susceptible for screening. And the way to do this is with AI. A quick thing, I don't want to go on about this, but when I read echoes, I'll ask the fellows what they think the ejection fraction is. And then I will tell them it depends on which cardiac cycle we measure. Because in any given patient, in apical views, apical 4, apical 2 chamber views, the ventricle is traversed in a slightly different way from cycle to cycle, and you get different answers. And I think AI can eliminate that. It can identify descriptors of the optimal view and say, this is the view to measure. And then we all measure the same view. We all measure it the same way. And I think that will be a huge step forward, because I can take an echocardiogram and probably make the ejection fraction anywhere from 50 to 60, depending upon which cardiac cycle I choose to measure.
Right. I fully agree with you. Thank you so much.
Well, perhaps we need a full dialogue on artificial intelligence. Perhaps one of our guests in the future can be artificial intelligence herself or himself. Now, I'm reading a long question from Thierry Gilbert, but I see that Thierry is with us. Why don't you ask the question directly? Please, Thierry, we are going to unmute you.
Okay.
Hello, Terry. See?
Hello, how are you?
I'm good.
Last time we met was in China.
Yeah.
At one of these meetings of the Great Wall. But let's go back to the question. Echo has appeared for decades as a less precise form of measurements that had to be validated against invasive pressure measurements, such as aortic stenosis, such as evaluating filling pressures. And the correlations invasive, non-invasive remain comparing apples with peers, will always be imperfect, and looking in this way will inevitably represent the non-invasive approach as an underdog. When you need to know pressures, you place a cat and you measure it. If you don't absolutely need to know the exact pressure, well, abandon the idea. I feel that we should increasingly work with non-invasive measurements in their own right and look at the intrinsic, diagnostic, and prognostic value of these measurements. And I believe that when echo Doppler will be freed from the restrictions of comparisons with invasive measurements, it will move forward easier. So this is a statement. What would be your thoughts or your position in this debate?
Yes, as you were speaking, I was thinking, how precise do we want to be? I think you and I agree 100%. Do we need to know the ejection fraction is 33? Or if we know it's less than 40, clinically, that directs us. And I think that in that regard, echocardiography, cardiac ultrasound fills the bill. It does what we want in the vast majority of instances. The pulmonary hypertension, we may not always be exactly on the mark that the catheter tells us, but we're very close enough so that clinically we can have actionable information. Ejection fraction is the same way for aortic stenosis. Really, honestly, if it's a decent echo, you can argue that the limitations of catheterization. I mean, you know, I spent a lot of years in the cath lab. I even did angioplasty for several years till I wised up and realized that there was an easier life as an imager. Invasive measurements have their own limitations, and for aortic stenosis, for pulmonic stenosis, etc. You know, I think that cardiac ultrasound may not be precise. I'm just repeating what you said. May not duplicate the invasive measurements, but it's close enough that from a clinical vantage point, it's extraordinarily useful.
Thank you,
I
Tony.
think for
Our audience is very active today. And we have another question coming from Albert Bigman, but I see you there, so perhaps you can ask your question directly.
Oh, I'm unmuted. Thank you. Thank you for this inspiring talk. And I'm a pediatric cardiologist, specialized in familial hypercholesteremia, sometimes difficulties with ultrasound to discover the calcifications and the plaques. And nowadays we have the rapid CCTA, where when the beats are below 70 per minute, it's hardly any radiation. What is your opinion? Is there place, even in pediatrics, for that new, in comparison with the wonderful ultrasound? I'm in favor of ultrasound.
Yeah, well, I think you make a really good point. I think that there are multiple imaging modalities out there, and that the most important thing is to pick the imaging modality that is best suited to answer the question that you're asking. And if you're asking a question about coronary arteries right now, about coronary anatomy, then it's clear that coronary CTA is absolutely the best imaging modality. It may get even better if somehow they can convince me that they can distinguish soft plaque from hard plaque, etc. And I think we're not quite there yet. But in any event, absolutely, the point you're making is right on. There's if the question is whether or not there's abnormalities in coronary anatomy, plaque and or calcification, then ultrasound is not going to help you at the moment. And do I see that changing? Is it conceivable that intravascular ultrasound or intracardiac ultrasound, ICE, can provide that information? Perhaps I suspect everybody's familiar now with the 3D pictures that are emanating from ICE transducers. Really very high quality. It's no longer non-invasive, of course, but nevertheless, it's providing the opportunity maybe to avoid ionizing radiation and contrast agents. Moving on. So I would agree with you entirely that if what you want to know is viability, then you know, my reading of the literature is that MRI probably is a bit more accurate than, let's say, dobutamine echocardiography, so that for viability in our institution, we tend to use MRI, even though I am always a proponent of ultrasound. And for following molecular targets, radionuclides remain the state of the art. So depending upon the question that you're asking, I think you should choose one or other of the imaging modalities.
Thank you. Thank you very much.
Thank you. I'm sure that Chiara agrees on these points. I see another famous colleague in the audience, Peter Lanzer. I've read your question, Peter, but perhaps better if you ask yourself.
Thank you very much for the opportunity to ask. Learning from our experience with mechanical thrombectomy in stroke patients, I realized how frequent the embolization is even in perfectly looking interventions. And I wondered, what is your thought about possibly using echo routinely to assess the microcirculation following the interventions? I'm not sure how frequent. I know the literature stating maybe 20% of patients do embolize or have disseminated embolization, but in stroke patients, it can be disastrous complication of the case. And so could you address this, please?
Yeah, it's an important issue, isn't it? Microcirculatory damage that is not assisted and maybe even worsened by the intervention itself. I think if ultrasound can help us, there will be the use of contrast agents. Contrast agents demonstrating perfusion, and an advantage there, if you couple it with an interventional procedure, is that you can do direct intracoronary injections of contrast agents, which yield very excellent images. The limitation of contrast has been to get very intense opacification with transthoracic imaging. But if you open the chest, for instance, in an animal experiment or at the time of surgery, or if you give the contrast agent intracoronary, intravascular, you can get spectacular images. And I think that is, well, there's already data showing that you can get persistent lack of opacification even after restoring flow in epicardial vessels. And I think that may well be the best way to get an answer about microcirculatory abnormalities, embolization that would be available.
Thank you, Tony. Well, you are a colleague with many talents, not only famous scientist, but also you've been a famous and important president of the American College of Cardiology. What can tell us about your experience as president of the college, and what would be your suggestion, your main suggestion to the current president of the American College of Cardiology?
So I was president of the college many years ago, they tell me I was the youngest president ever of ACC in my early 40s, before I had sufficient wisdom. In any event, it was a different time, Filippo, and you know, when I was president, it was a time when there was just this awakening of how much healthcare costs society, and governments were becoming involved in, and the private sector, manufacturers were becoming very, very involved, saying the insurance for their workers was making them non-competitive on a world marketplace, and so that's a lot of the direction that I imparted to the ACC when I was president, that cardiologists had to take a leading role in identifying what was cost effective, what was the best management of any given condition, diagnostic or therapeutic. And I think that continues to be a major factor. We can see as these new therapies become available, PCSK9s, I don't know in Europe, but in the United States, there was a great reluctance to have either the government or private insurers pay for those agents. We'd have to go through a lot of hoops to get our patients on them. So I think that is something that a professional society can do better than any other organization. And it should be not only incumbent upon us, but an opportunity to do things and to promulgate guidelines that are just guidelines. It represents what should be best in 1,000 patients, but not should be best in any single individual patient. That the physician and the patient have to decide for themselves. And of course, education. And the European Society certainly has demonstrated that with their meetings. National societies can be the most objective form of education without any worry about bias being introduced. So I think those are the areas at the moment that I would advise the president of the college to be most involved in.
Well, I'm sure I will be very grateful to you listening to these excellent suggestions. But I see Chiara, she's ready for some more questions. Chiara, please.
Yeah, I have a couple, but there is also an interesting one in the chat that maybe you want to pick that up and is relevant to the journal. So I wanted to ask you, Prof. DeMaria, is as it transpired from this dialogue, the cardiologists have access to multiple imaging modalities. And in fact, the collaboration with the radiologists are increasing, but also the cardiologists are getting more involved with CMR and CT. So what advice would you like to give to the community of cardiology, well, cardiovascular imagers, including radiologists? What recommendation would you give?
Well, the recommendation is that I think cardiologists and radiologists bring different expertise to imaging. Most radiologists are not as versed in physiology, pathophysiology, and clinical care. The care of the patient. conversely, most cardiologists are not as well versed in the physics and instrumentation of certainly MRI, CT, even isotopes. So that combining those two expertise is a spectacular way to go. And in the United States, the only thing that, or the major thing I should say, that has prevented that collaboration being fully implemented is money. You know, who gets the reimbursement? And so the way we've settled it at UCSD is we split it. And when money is no longer a factor, it's amazing how collaboration can occur. And if you take radiologists and you take cardiologists and you throw in some bioengineers, then it really, the cross-education, the cross-fertilization, the ideas that come from the cardiologists to the bioengineers and radiologists, it can be extraordinary. So I think you're seeing that more and more in the United States. As I say, we've been very fortunate in San Diego. From day one, we said, let's get money out of the equation. Money is not a factor. And when money goes away, then it's only fame that enters the picture. Who's going to get the credit? I have a sign in my office that says it's amazing what can be accomplished when it doesn't matter who gets the credit.
Very wise. Yeah. Very quick final question for me, because I'm sure Filippo has a couple of more. What advice would you give to the cardiologists doing imaging nowadays, both the younger generation and the grown-up like me and others?
The advice that I would give would be to try to get a foundation in all of the techniques, but then to focus, to focus and have your investigational activities very much focused on one or the other. I don't think that this concept that one person can be the expert in every single imaging modality. It's just too difficult. We have an integrated imaging program at UCSD, and when the patient, when these individuals come out, they can do echo guidance of interventional procedures. They can read MRIs, CTs, nukes, etc. But there's someone at UCSD who's better at each one of those things than they are. So I think it's good to have a broad foundation in imaging, so you know what techniques are best for what patient. But my advice would be to pick one imaging modality and say, this is one I'm going to be sure that no one knows more about this modality than I do.
Well, thank you. Back to Filippo for a final question, perhaps.
Thank you, Chiara. Well, I said before, a man with many talents, top scientist and mentor, important president of the American College of Cardiology, but you've been the successful editor-in-chief of the Journal of the American College of Cardiology for 12 years. And I still remember a famous editorial you published in 2014 about your experience as editor-in-chief. Now, we have a joint question from me, editor-in-chief of the European Heart Journal, and from Nico Bruning, who, as I told you before, is editor-in-chief of Digital Health. And the common question is, How can we improve what we are doing as editor-in-chief based on your massive experience?
So journals are in transition. I think this dialogue is one example of that. For years, we've seen the New England Journal, a journal that's supposed to be directed toward novel investigation, new findings, doing more and more articles on even how to do procedures and whatnot. So that I think as time goes by, that I apologize. There's a phone in this office, and there's nothing I can do about it.
So stop it.
I should have tried to unplug the darn thing. Anyway, journals are changing, right, Filippo? I mean, I remain as an editor of a smaller journal called Structural Heart. So we're going more online, less in print. We're going more open access. In 5 years, I'm convinced that subscriptions are going to be minimal, that more and more is going to be open access. And we're going, I think, more from the position of the purpose of journals are to bring forth new information that's past the crucible of peer review. I mean, because ultimately what journals bring that no other form of information brings is the fact that the information has been scrutinized and evaluated and often revised so that it represents as close to the truth as most people think it can be. And in the final analysis, there's a gazillion outlets for review articles, right? There's lots and lots of, and there's lots of opportunities to see imaging. My goodness, you can Google any condition and see every image that's ever been made of it by every technique. But only journals can take new observations, new hypotheses that were tested, and provide the best answer, but not that it's always the correct answer. You know, we screw up. There are people out there whose manuscripts I rejected over the 12 years. We do make mistakes, and maybe I made a mistake with their manuscript, but it's the best way of bringing new information forward. And I think that should always be the most important objective of journals.
Thank you, Tony, for sharing with us your wisdom. And definitely you're right. Journals evolve, and it is important to follow this evolution. Journals are important for the dissemination of knowledge, and this is a big responsibility. But journals are also responsible for creating a feeling of community among cardiologists. And this is what we are doing today, for instance. Three important challenges.
Absolutely, and I congratulate you, and it's a privilege to be involved.
Thank you, Tony. Nico, one final comment from you as editor of Digital Health.
What you said earlier, to bring together, let's say, interventionalists, bioengineers, cardiologists, imagers all together. I'm very pleased to have a journal now, Digital Health, trying to connect, let's say, technology side with the clinic. How do you see that further going? Should we integrate also the engineers in the clinical decision support discussions we have within the hospitals, bring them closer to the bed of the patient instead of that they are a little bit out of a distance?
Yeah, I think that that's very important. We have one of the foremost schools of bioengineering in the United States here at UCSD. And all of those bioengineers come over and spend time in the hospital. They gown up for catheterizations. They sit in the echo lab as we interpret studies. I think it's really important that they understand what we do so that they can help us. And oftentimes, well, at least sometimes a bioengineer will come and say, listen, I've developed this sensor, or I've developed this imaging technique. Do you think it would be useful? And that gives us the opportunity. So it's a two-way street. The bottom line is, I'm a very strong proponent of having bioengineers and radiologists and cardiologists involved in clinical activities, so everybody understands what the ultimate objective is.
Thank you, Tony. Chiara, any last remark from your side?
No, I just wanted to say a big thank you, because I've learned so much, and it's been a very inspirational dialogue. And I'm sure for all our attendees as well.
Well, it looks like that we started only a few minutes ago, but it is more than 1 hour. And this is evidence that it has been indeed a fascinating dialogue. Thank you, Tony, for dedicating your time to the European Heart Journal for this fascinating dialogue. Thank you very much. Thank you, Chiara. Thank you all the colleagues who asked questions during this dialogue, important, critical questions. Thank you, all of you. And I remind you that our next dialogue, as usual, will be on the last Thursday of the month, in this case, July, on the 28th of July at 17 Central European Time. Tony, Chiara, all the others, thank you very much for this fascinating conversation. Bye-bye.
Thank you. Bye-bye.
Thank you for the privilege.
Thank you, everyone, for joining, and have a lovely day. We'll just briefly wait for everyone to sign off.